We'll be talking about our project Understanding Access to High-Cost Novel Cancer Therapies, a survey for pediatric oncology providers. There are no conflicts of interest to disclose. And we'll start off by just talking about how innovative therapies have continued to expand their use in pediatric oncology. But as many people in this room will know, many of these are high cost and not currently funded publicly. So when we have a new therapy in Canada, it gets submitted with an application to Health Canada, and then there's a decision made on approval for sale and marketing. And concurrently, there can be an application made to the Canada Drug Agency, which then makes reimbursement recommendations to the provinces and territories. Importantly, the provinces and territories then make a decision on their own about what happens with each of these therapies. And so what this leads to is varying levels of reimbursement from all of these different provinces and territories. The other thing that I haven't included on here is proton therapy. So people will know that proton therapy is something that has had increased use as we have continued to expand its indications in pediatric oncology, but we don't have a center here in Canada. And so our patients all go to the United States to access proton therapy. This is going to become salient as I talk about the actual survey, but I just wanted to highlight that big disparity there. We also know that patients across the world experience different access to these high-cost therapies. So we see that in the US, we see that in Europe, and underserved populations, unfortunately, can be in situations where they're not offered evidence-informed drugs such as blinatumomab and cellular therapy due to prohibitive consumer costs as well as logistical complications. We also know that exposure to poverty and lower socioeconomic status have been shown to impact selection of certain therapies for patients and ultimately relapse rates. And in the US, children from households with higher incomes and with private insurance were much more likely to receive proton therapy than those that did not. And unfortunately, we can't translate all of that to our Canadian context. So as I mentioned, we have a different drug approval process, there's different public funding, and we also do not have a proton therapy center in Canada. And so to understand disparities in access to these high-cost therapies, we devised an online national survey where we selected 4 evidence-informed therapies that were not universally funded. So this includes blinatumomab for patients with low-risk first relapse of B-cell ALL, larotrectinib for pediatric TRK fusion-positive tumors, proton beam therapy for unresectable head and neck sarcomas in children, and then cellular therapy or tisagenlecleucel for patients with Down syndrome and first relapse of B-cell ALL. And all of these have strong evidence supporting their use, but unfortunately are not universally funded across Canada. The survey was designed with vignettes, looking at all of these different 4 drugs in those specific situations, and was distributed to pediatric oncology clinicians across the 16 pediatric oncology centers in the fall of 2024. Participants were contacted directly by email or through email distribution lists of the ACCESS Network, C17 Council, as well as CARO, or the Canadian Association of Radiation Oncologists. The primary outcome was the ability for patients to access each therapy. So this is provider reported again. And this was defined as the patient's ability to actually receive the specified therapy. Secondary outcomes also included time to access, funding sources, and perceived barriers to access. And we also asked questions around some other themes, including other indications for access, the process for obtaining access, and then, as I mentioned, time, funding sources, and barriers. So we'll move on to results. We had 70 participants from 15 centers who started the survey, and 68 completed at least one question. So those are the participants that we actually analyzed in results. The majority were pediatric medical oncologists. So you can see here about close to 50%. There were some radiation oncologists as well as pharmacists, and then nurse practitioners and advanced practice nurses as well. We had representation across the country. So as I mentioned, across 15 centers, the majority of participants were from Ontario, but we did have good representation from Western Canada, Quebec, and then a few in the Atlantic provinces as well. Now, if we look at provider-reported access, we saw that for blinatumomab, providers reported that they could access it 89% of the time for the indication in question, larotrectinib 79% of the time, proton therapy 59% of the time, and then cellular therapy 94% of the time. And I'll draw your attention to the proton therapy column just to highlight the variability that was noted across the different provinces. So we had 33% in Nova Scotia going all the way up to 100% in Manitoba, and then everything in between. There was less variability noted in cellular therapy, but still some uneven distribution of access that was reported across the country. Important barriers that were highlighted were it being cost prohibitive, specifically for larotrectinib, the emotional and psychosocial impact of travel, as I've already highlighted for proton beam therapy and cellular therapy, patient complexity making travel complex. So you can imagine patients that have a bunch of different comorbidities. How are they going to travel and get all of that different care? And that was salient for proton, cellular therapy, and blinatumomab. And then visa and immigration restrictions for proton beam therapy, which becomes even more salient as things have progressed in society in general. Even access to these high cost evidence-informed pediatric cancer therapies and these notable barriers, including economic and psychosocial impact of travel. We saw that funding sources are very varied, and that we do need some supports to be able to alleviate the cost of other costs associated with travel, including accommodations and food. And then really, I leave you with this thought that these variations in access really challenge the notion of our truly universal healthcare system for children with cancer in Canada. We published this as an abstract for the ASCO 2025 annual meeting last year, and the manuscript is currently submitted for publication and under review, so hopefully that comes out soon. And I'd like to thank everyone on our team, but especially Paul Gibson for all of his mentorship, guidance, patience, and time with this project. And then Avi Denberg, Celine Cressman, Derek Sang, Mayanka Rodriguez, and Marcel Romanek, as well as the ACCESS Network. Thank you.
We now have some time for questions. David in the back.
This is great, Kriti, and I just wanted to make a comment, just as a social worker who works with families who go to the States for proton, that one of the other aspects currently is the political dynamics in the US and the challenges for families who are quite diverse or who are here on visas, that the travel there and the considerations and to be honest, the stress has also changed because of that. I'm not sure how that's going to change over time as well.
Yeah, you're absolutely right. And I think it just underscores the importance again of having local assistance. And we've seen that with other access to clinical trials and so many things where we've been dependent on the US and seen that we've actually lost a lot of support for that. So I think that that's just another example of really trying to be our own independent group.
Heather, yeah.
I'm just wondering as well if you're going to consider looking at the psychosocial impacts of families being separated from each other or being separated from their communities while they receive that kind of care. Because when you're talking about these 6 and 8, and we know families as much as 12 and 16 weeks or longer that are separated from their, not just their community, but from siblings, from the other parent. I mean, when you're talking about some of these palliative care and stuff in these families during really critical times, so there's big impacts.
There's huge impacts there, just like you said, and that's actually well reported. I mean, I think we all hear that as clinicians from our patients, but then we also see that a lot in the literature, that there's actually worse psychosocial outcomes, even long-term, for patients when they experience fragmentation of their family, when they have to go to different places for treatment. So that is something that is well reported. We talked about it a little bit in our manuscript as well, but we didn't explore that quite in as much detail as we would have liked, but definitely a further area for